We'll move swiftly to the next monoclonal drug, which we'll be looking at its pharmacology. And here we're trying to look at drug known as alirocumab. Alirocumab. All right. So looking at this drug, this is how it looks like, and it goes by a very popular brand name known as what? Praluent. So sometimes you see people writing it Praluent. Praluent is still the same alirocumab. Okay. So you should know that it's a fully human monoclonal antibody, and in summary, usually acts on the proprotein convertase subtilisin, or casein type 9. And the primary aim is to reduce what? The amount of bad cholesterols you have in the body. So the bad cholesterols, we call them the low density lipoproteins. The good cholesterols, we call them the high density lipoproteins. So what's the mechanism of action? It targets this PCSK9, which is a protein that usually binds to low density lipoprotein receptors on on the cells of the liver. So by blocking this protein, you are preventing what? The continuous, conversion, or you are preventing those receptors of low density lipoproteins from responding to low density lipoproteins. So effect. Sorry. Okay, wait. You are dropping down the receptors of low density lipoproteins, but you are increasing. Okay, let's just put it like this. You are basically increasing the number of receptors that will clear low density lipoproteins. The ones that will make it work, you are decreasing, but the ones that will clear them out of the system, you are increasing. Okay. So when you give this drug, you see that there's a high level of drop in low density lipoprotein levels in the body. Okay. So instead of them binding on some receptors and having a grip and staying back in the system, you are blocking those receptors and trying to increase receptors that will rather what? Clear them out of the system. So pharmacokinetics is usually given subcutaneous. Absorption, the peak concentration is reached between 3 to 7 hours. Distribution is confined largely to the vascular and the interstitial compartment. Metabolism is proteolytic degradation. So half-life is about 7 to 20 days. So you dose it every 2 weeks. So pharmacodynamics, it will reduce these low density lipoproteins by 50 to 60% when added to statins. Improves cardiovascular outcome, clinical use, adults with heterozygous familial hypercholesterolemia, patients with clinical atherosclerotic cardiovascular disease, then also patients that you would have given them statins, but basically they are intolerant to statins.